establish a piggyback infusion of a medication. So we'll be using the same criteria that you all have been using in Platinum Planner, including the critical criteria. And if you do, fail on one of those critical criteria, that will be, well, the critical criteria will we primarily be using to determine whether or not you were successful at station. So as far as the grading goes, what will happen is if you come in and you're successful and you don't hit any of the critical criteria, you get 100%, you get all the points. If you do fail and you end up having to retest, you are allowed to retest, but you will only be able to get a maximum of an 80% on the retest. And then if you do not pass the retest, then we will have to set up a conference between yourself and me to figure out what the next steps forward will be. But again, it should be a fairly straightforward. This is what you've been doing. You spent all week doing this, practicing this. The medications that we've been using throughout the course, throughout all the labs. You should be very familiar with them at this point. So there really aren't going to be any surprises. Just remember things like asking about allergies, making sure you wipe ports down with alcohol before you access them. Make sure that you label if you are mixing something. Obviously, if it is a pre-mixed solution that is already labeled, then you don't have to do that. But if you mix something, make sure that you label it and make sure that you eliminate error in the lines. Make sure that if you're going to give something that you eliminate error, if it's a pre-filled syringe or you're drawing something up and administering it, just basic things like that. Make sure that you are using good sharps discipline, right? You use a needle, toss that needle immediately. Don't try to recap it or do anything like that. Just get rid of it. And you all should do fine. Again, you won't have to do a whole lot of decision making. You're going to receive an order to administer medication. It'll be appropriate for the clinical context. And so really fundamentally what today is just you demonstrating that you can safely administer parenteral medications. Any questions about that this afternoon? Anybody have any questions? Okay, well, we have another review quiz that was due. So I'll go ahead and go over that real quick. And there are just a few other things I want to talk about medication pharmacology wise, and then we will wrap things up. This will be, of course, the final lecture for pharmacology. We will be moving on to ECG interpretation tomorrow. Just as a reminder, tomorrow will be an all-day lecture. And we're going to do this in an attempt to try to cut down on the amount of driving and commuting that everybody has to do, because the gas prices, of course, have not gone down, and in fact have gone up in many venues, many areas. So tomorrow will be an all-day lecture, and then Thursday will be an all-day lab. So you will be at the college all day. So the way that that's going to work, and I'll talk about that in the review of the syllabus tomorrow, but essentially we'll meet at 8:30 at the same time. We'll lecture, then I'll let you go for lunch. We'll have an hour and a half, 2-hour lunch, so you get a good little break, and then we'll meet back up in the afternoon and do a couple more hours, 2-3 more hours of lecturing. Same thing with the lab. We'll meet in the morning. We'll do a round of labs in the morning. You'll get a good lunch. You'll come back in the afternoon. You'll do a round of labs in the afternoon, and then class will be adjourned. So we'll see how that works for everybody and see if that doesn't help out with scheduling and whatnot. All right. So I'm going to go ahead and share the quiz with you all. So let me go into there. This is going to be review quiz number 4. All right, there we go. take it, just cancel that. And we'll do a preview. I don't think there were any dosage calculations questions on this particular quiz. All right, which of the following is the most concerning problem associated with vaccine administration? Anaphylaxis by and large is our biggest concern. And let me ask a question. Well, you all had to do a drug card on just vaccines in general. Are we able to administer vaccinations as EMS providers in the state of New Mexico?
Yes.
We are, yeah. Not under general circumstances, but in the setting of public health crises or emergencies, we are allowed to administer vaccines. And in fact, our program has been involved in that when it comes to COVID-19. Some of the students have volunteered at the various vaccination pods, although most of that has now died down now that we're really not fundamentally in a public health emergency per se. But yeah, so as EMS providers, we are able to administer vaccines, but there are certain conditions that have to be met. And there are many different vaccines and many different ways that the specific ways that they work, right? Some of them use what's called an attenuated virus, or you take a virus and you deactivate it. And then that deactivated virus is what initiates the immune response, or maybe you just use a part of a virus, just the antigenic component, part of the cell wall or a protein, or not a cell wall, but part of the viral capsule, or just a protein, and use that. Sometimes you'll use a protein and then mix it with something called an adjuvant. What an adjuvant basically just enhances the immune response. Generally, adjuvants are metals that kind of enhance the immune response. More recently, we have taken a messenger RNA that goes to ribosomes and codes, actually tells the cells, typically muscle cells, that's where vaccines get injected to into muscles, tells the cells how to create these proteins, like spike protein, for example. And then you package the messenger RNA in a little capsule, a lipid nanocapsule or nanoparticle that can deliver that. So there are many different ways of doing it, but they all do the same thing in that they initiate the immune response and they contain antigens, and the body recognizes those antigens. The B cells start cranking out antibodies, and then of course the B cells can retain memory and become converted into their active plasma cells if you get infected later on. And that's generally how vaccines work. And so since you are modulating the immune system, the most immediate problem is always going to be anaphylactic reactions. And that's why there is generally a waiting period after somebody receives a vaccine, right? And depending on the vaccine, there may be additional side effects or additional considerations. Certain vaccines use eggs. Eggs are used in the creation of the vaccine. That's not as common nowadays, but occasionally that happens. And so people that have various allergic conditions, some of the vaccines may be problematic for them. And obviously people that have had prior anaphylactic, say, reactions to a specific vaccine, that would be contraindicated, generally speaking. And of course, those are important questions that we always need to ask people prior to administering a vaccine, right? What allergies have they had? They have prior reactions? Do they have certain allergies or insensitivities to the technologies that are used to create some of these vaccines? All right. Moving on, postpartum continues to hemorrhage following uterine massage. Infusion of oxytocin or Pitocin would be indicated. All right, which blood product will replace all clotting factors? What do you all think?
fresh frozen plasma.
Absolutely. And that's the primary reason that we administer FFP is to replace clotting factors. Fresh frozen plasma can act as a volume expander to an extent as well, but it's primarily used to replace clotting factors, all of the major clotting factors. Which of the following is the most common type of blood product reaction? By and large, and we've talked about this with blood products, by and large, it is a hemolytic reaction, right? Hemolysis is a breakdown of blood. That is by and large the most common, the most pressing, the most relevant transfusion-related reaction that we need to be concerned about. Patient missed a week dialysis and presents with a wide complex dysrhythmia without P waves on the monitor. Which medication may be indicated? So essentially, this paints the picture, the history of someone who may have life-threatening hyperkalemia. And so calcium would initially be indicated for them. Okay, moving on. Which medication may have a role in treating GI, gastrointestinal bleeding? Even though some controversy surrounds the discussion of how effective this drug may be. And so that would be octreotide or sandostatin. It's a hormone modulating agent. Lisinopril is an ACE inhibitor for primarily for blood pressure, congestive heart failure. Furosemide is a loop diuretic. Oxytocin, of course, we just talked about that. Quote unquote universal donor. There's actually, in a strict sense, there's no such thing as a universal donor, because blood contains dozens and dozens of potential antigens. But the safest bet, if you will, if you're going to give uncross-matched blood to somebody, the best bet would be to give them type O negative. Which is the most concerning complication regarding tube feeding a stroke patient with nutritional supplements? And of course, you had to do a drug card on nutritional supplements in general, not all the specific ones out there, just know about them in general. And so the most concerning complication here, someone's had a stroke, you want to be concerned about their ability to swallow, manage secretions in their airway. And so aspiration would be our biggest concern. Can you have gastrointestinal side effects when it comes to tube feeding? Yes. So you can have loose stools, you can have blood sugar changes, you can have inflammatory changes. All of those are possible. But the most concerning, of course, would be if somebody aspirates and develops aspiration pneumonia, pneumonitis, and then they go down that path of ARDS, SIRS, sepsis, severe sepsis, septic shock, multiple organ dysfunction syndrome, etc. Okay, the administration of which medication may prevent the onset of Wernicke's encephalopathy in chronically malnourished patients who receive boluses of dextrose? And of course, that would be thiamine, or vitamin B1. Patient develops severe abdominal muscle spasms and pain following black widow envenomation. Which agent may, I want to emphasize, may play a role in treating this patient? What do you all think here? Calcium, yeah. And the effectiveness is very questionable here, but I included this question because this is technically one of the indications for calcium per the New Mexico scope of practice, and part of the this pharmacology class is ensuring that you have basic familiarity with New Mexico scope of practice. That's why I have the state guidelines loaded into Canvas in addition to our specific clinical practice guidelines. So pharmacology is one of those weird classes where there are lots of different hats that you have to wear, things, paradigms you have to juggle. You have to understand from the national curriculum medications, things like nitrous oxide, for example, that we don't use in this state. You also have to understand about the state scope of practice. And then, of course, you have your individual clinical practice guidelines, which are a reflection, or should be a reflection of the state scope of practice. And you're going to run into these inconsistencies throughout the paramedic course, where there are going to be differences in guidelines. Generally, the differences aren't huge, but sometimes they can be substantial, and that's just because clinical practice can vary somewhat from place to place, and so you just kind of have to take that into consideration. And people may tell you slightly different things, or may have different ways of doing things, and part of what you're going to have to do as you become a paramedic, particularly during clinical rotations and during your capstone or your internship, is kind of synthesize that and kind of pick and choose what works best for you in your specific clinical practice. And on many times that can take a few years after you graduate school to really kind of figure out certain things that work best for you. So a lot of what we do here is, honestly, from my philosophy, from my philosophical perspective, a lot of my job is to try to give you the tools that you need to succeed. So I give you a toolbox, I talk about lots of things, give you the tools, and then you kind of have to figure out how to use them, and throw things away that don't work as well for you, keep things that do work as well for you, while always remaining as flexible as possible, because medicine changes, very dynamic. And even in the period of a couple of decades, which may seem like a long time for some people, but it's actually not. My career is spanned over 20 years. When I started in the 90s, there were things that we did in the mid 90s when I started, that we don't do anymore, are completely different, in fact, dangerous, like certain trauma care that we were taught as a standard of practice, right? We gave large volumes of crystalloids to trauma patients. And I remember one of my guidelines was, if I didn't dump at least 2 liters of crystalloid into my major trauma patients, that was I would be considered an inappropriate provider, a poor provider for not doing that. Now we understand that large volumes of crystalloids are very problematic, right? With hemodilution and acidosis, you're doing lots of saline, causing hypothermia, et cetera, et cetera. Mast pants, for example, were a very substantial part of scope of practice. In fact, I used mast pants a couple of times on actual patients, in a clinical situation. It was patients that had, what was it? I think it was like intra-abdominal pathology, something. I forget it was the couple of times that I used them, but I haven't in the last 20 or so years. So things change quite a bit. Guidelines change quite a bit. In fact, fairly recently there has been a big change, and those of you that have flip books, you may even notice this. If you look up atropine in your flip book, it very well will say 0.5 milligrams IV push for symptomatic bradycardia. That was actually updated in the 2020 ACLS guidelines to 1 milligram IV push. So, even things that are fairly well established can change. So you just kind of have to remain as flexible as possible. Okay, so that's the quiz out of the way. So let's move in and talk about some of the topics that I want to get through today. So there are 2 major categories of agents I'm going to talk about. I'm not going to talk about them in any substantial detail, because there are so many different classes of drugs in these big categories, subclasses, subcategories of drugs, but we'll just kind of look at the big picture. And I'm going to be talking about the oral antihyperglycemic agents. These are typically used in the management of type 2 diabetes, mellitus, and we'll also talk about lipid and cholesterol medications. But prior to that, there are just two additional medications a medication and a paradigm that I want to briefly cover. You've talked about these already as in your basic, in your EMT course, pharmacology class, and your advanced EMT pharmacology class, but I just want to make sure I at least mention them so we're covering, we're being as holistic as possible. And that is, these are toxicological in nature. And so let me just go ahead and do a screen share here. And that's going to be talking about charcoal and some nerve agent antidotes. All right, so as far as charcoal goes, nothing has really changed from what you've learned in prior classes. So activated charcoal, right, acts primarily as a binding agent. It binds to certain medications, and essentially it alters the pharmacokinetics of the medication, and it prevents GI absorption. And there are many agents where charcoal is relatively ineffective, right? It's not like it's super effective. And the indications for charcoal there are some very specific caveats. So the most important caveat is airway. The patient needs to be awake, alert, oriented, and they need to be able to spontaneously manage their airway. If they're not, that is a contraindication. Now, in some instances, if you have a patient that's not protecting the airway, but you're protecting the airway, maybe that patient, you've intubated them and you have control of their airway, you might consider giving charcoal in that specific case. But if the airway is a concern, then charcoal would be absolutely contraindicated. So that's a big one. Time is another big one. Typically, if you're more than an hour or so out from the ingestion, charcoal is going to be far less effective, right? So generally, you want to give charcoal if this is very early on, within the first hour or so, is most ideal. All right. And then there are certain agents or substances where charcoal is contraindicated. For example, if someone has ingested a caustic substance, so some sort of hydrocarbon, right, like a paint thinner or something like that, or something that is very acidic, or something that is very basic or alkaline, right? So if you have a history of those sorts of ingestions, charcoal would be generally contraindicated because it can increase the risk of aspiration. And then you have acids and alkali and hydrocarbons coming up, and they're getting aspirated. They're causing additional damages are coming up potentially. And so if there's a history of that kind of ingestion, then charcoal would be generally contraindicated. All right. What's the dose of charcoal?
1 gram per kilogram.
Yeah, that's typical. 1 gram per kilogram. And from a technical standpoint, we tend to want to do like a 10-to-1, right? So you give 10 parts of charcoal for every 1 part of poison. So somebody's overdosed on 1 milligram of some sort of substance, you'd want to give at least 10 milligrams of charcoal. And 1 gram per kilogram tends to do that in many situations of overdose. Now, charcoal comes in a couple of different configurations. It does come in a powder that sometimes you have to add water to, but typically it's going to come as a suspension where the charcoal is suspended in a liquid. But the two major forms of charcoal are going to be with sorbitol and without sorbitol. And does anyone know what sorbitol is? So sorbitol is a kind of sugar that we cannot digest and use, and so your body tends to get rid of it, doesn't like it very much. And so essentially what sorbitol acts is it acts like a laxative. So it makes you poop. And so the reasoning for mixing sorbitol in with the charcoal is that the charcoal kind of helps bind and prevent absorption, and the sorbitol decreases the transit time. And so you have that stuff, whatever it may be, and the sorbitol helps promote flushing it out of the GI tract, if you will, via causing diarrhea. So that also means that when you're giving charcoal with or without sorbitol, the underlying physiology of the gut will be important. And so if there is a concern for, say, a GI obstruction, either a large or a small bowel obstruction, charcoal would generally be contraindicated as well. All right, so that's charcoal in a nutshell. The other thing I want to briefly talk about is nerve agent poisoning. And we've talked about these before, but I just want to talk about them in just a bit more detail as far as antidotes. And interestingly enough, this is very rare in the United States, but nerve agent poisoning is among the most common overdose we see worldwide. And that's because people tend to overdose on things they can get a hold of very easily. So here in the United States, for example, people tend to overdose on ethanol, on alcohol, first of all, right? Because it's very easy to get a hold of. And then they overdose on over-the-counter and prescription medications, right? Acetaminophen, Benadryl, all the various antipsychotics, antidepressants, blood pressure medications, right? These are all fairly common things that people can overdose on because they're common, easy to get a hold of. But in other countries, that may not be the case. So countries like, say, India, rural India, where people aren't able to necessarily get a hold of a bunch of Tylenol and alcohol, but what they can do is they can go to the village gardening cabinet, open it up, and ingest a bunch of insecticide. And so we actually see lots of nerve agent toxicity worldwide. In fact, people who want to learn how to manage nerve agent poisoning will go to these countries and do fellowships, toxicology fellowships in places like India, for example, where this is very common. So the common device that we see here in the United States is something called the Mark I kit, or the nerve agent antidote kit, and it contains auto injectors. So it's similar to the EpiPen, right? The epinephrine auto injector that they make for adult pediatric patients. And this contains two different auto injectors. The first is an atropine auto injector, 2 milligrams of atropine. And then the second, a larger syringe, is a syringe of parladoxine chloride, which is an oxime, also referred to as 2-PAM chloride, 2-parladoxine chloride. And oximes, and this tends to be a 600 milligram auto injector. So oximes may, and I want to emphasize may, reactivate acetylcholinesterase. So remember, the problem with nerve agents, both the carbamates and the organophosphates or the organic phosphorus agents, is they block the action of acetylcholinesterase, right? And acetylcholinesterase is the enzyme that catalyzes the breakdown of acetylcholine. So it actually, there's a hydrolytic reaction, and acetylcholine breaks down into acetic acid and choline. And so you block that enzyme, and you have an accumulation of acetylcholine in nicotinic and muscarinic receptors, and that creates a cholinergic crisis, right? And so in some situations, 2-PAM chloride might reactivate the acetylcholinesterase. And there's a process called aging that occurs with nerve agents. And essentially what aging is the amount of time it takes for the nerve agent to form a permanent bond with acetylcholinesterase. And once a permanent bond is formed, then it doesn't matter how much of the oxime you give, you will not be able to reactivate the acetylcholinesterase, and you essentially need to wait for the body to create more, right? And every nerve agent has a different time to age. Some nerve agents, like the carbamates, for example, so things like pyridostigmine and phosostigmine, neostigmine, are completely irreversible. They don't age at all. So they tend to be less toxic, whereas the organic phosphorus or the organophosphate agents will undergo aging. And the weaponized agents tend to age much faster. Some like, I believe Soman, for example, ages within about 2 minutes, whereas others can take, much more time for aging to occur. Interestingly enough, when we do research in countries where this is very common, the evidence for 2-PAM chloride is very contentious. There are lots of studies out there that show that sometimes giving 2-PAM chloride can result in harm, can either not be helpful or be harmful in some patients. And so the overall effectiveness of 2-PAM chloride in the setting of nerve agent toxicity is a bit contentious, but clearly the atropine is going to be incredibly important and play a big role because it is the anticholinergic. It is the antidote, so to speak. Now, when it comes to the Mark 1 kits, generally they recommend that you give them every 5 minutes or so until you get signs and symptoms of atropinization. But when it comes to giving atropine, and I mentioned this in lab, typically what we'll do is you start with your initial dose, and then every 3 to 5 minutes, you double the dose until you get control of the killer bees, right? So remember we talked about cholinergic crisis sludge plus the killer bees. And so the killer bees are the things that are more immediately life-threatening, the bradycardia, the bronchorrhea, and the bronchospasm, right? And so when you get the patient's heart rate stabilized, they're not wheezing and their lungs aren't full of mucus, then they're adequately supported with an anticholinergic. And so typically what we do is we start off with 2 milligrams of atropine, and then you double the dose. So you go from 2 to 4 to 8 to 16 to 32 and so on and so forth, right? And so you can see that in a severe case of nerve agent poisoning, These patients may require hundreds of milligrams of atropine, sometimes thousands of milligrams of atropine, because some of these nerve agents are very lipophilic, and so they go into your lipid, go into the lipid compartments of your body, and then just stay in there. And then over time, they slowly leak out of those compartments, and so you can have this prolonged toxicity that can occur. And so these people may be on atropine infusions for several days, if not longer, depending on how lipophilic the nerve agent in question is. So it's definitely not like the movies, right, where you stab yourself in the heart with a Mark 1 kit and you're instantly better, right? These patients tend to be pretty sick. They tend to require lots of supportive care, and they may require very large and frequent doses of atropine to support them. Luckily, this is not something that is very common in the United States, at least, but it does occur, and it is very common worldwide. All right, so any questions over charcoal or the Mark 1 kit? Anybody have any questions over any of that? What other drugs are probably going to be really important when it comes to treating a nerve agent exposure, aside from atropine and possibly 2-PAM chloride? What other drugs do you think are going to play an important role here?
Maybe ipratropium?
Yeah, you're on the right track. Yeah, you're definitely on the right track. So atropine is going to play a critical role, but don't forget the other part of the killer bees is the bronchuria and the bronchospasm. And so these patients can be very wheezy, can have lots of mucus secretion. And so administering beta 2 agonists like albuterol and possibly, right, and possibly inhaled anticholinergics like ipratropium or Atrovent may play a very important role in managing these patients, right? So don't forget that they can have lots of wheezing, lots of bronchospasm. So that's going to play an important role there as well. Okay, excellent. So before we move on, are there any questions over anything we've covered so far? Okay. Well, what I'm going to do is I'm going to pull up notes, just some basic notes on the antihyperglycemics and the cholesterol/lipid control agents. So let's talk about the antihyperglycemics. And again, this is going to be a fairly rough overview. So this would be very, very high altitude overview, if you will. So when we talk about how we treat hyperglycemia, remember that the primary problem with type 2 diabetes is insulin resistant cells, right? And so you have this metabolic, it's really a metabolic disease, a disease of metabolism. And so the medications that we use work in various ways. So some of the medications do work by causing increased insulin secretion, right? And so you've got drugs like these sulfonylureas, for example, are very common. Let me choose a slightly different color here, right? Your sulfonylureas work by increasing insulin secretion. Other medications work primarily by decreasing glucagon secretion, right? Such as the incretins And I know you covered some of the major categories in the deep dive review videos that you had to do. So I'm not going to spend a great amount of time talking about the specific mechanisms. Some of these work in the gastrointestinal tract, such as the incretins. So the incretins have multiple mechanisms of action, right? And they can help prevent absorption of certain things. And for whatever reason, decreasing certain types of bowel function does result in an improvement of insulin resistance. And in fact, sometimes people that have gastric bypass surgery will have a marked improvement of their blood sugar, and the mechanism isn't really well understood. We don't know the exact mechanism, but it does seem to be effective in some people. Other drugs are going to work in the liver, and they're actually going to modify systems within the liver to decrease glucose output. So the liver's not pumping glucose out into the body. And so your biguanides, for example, are going to do this. And the major biguanide, of course, is metformin or glucophage, right? Other categories of agents are going to work on fats, right? Because we can break down fats and through beta oxidation and feed that into gluconeogenesis pathways. And so you can attack fat or lipid metabolism, right? You can also impact glucose uptake, right? Help certain cells like muscle cells uptake more glucose so you have less glucose in your blood, such as the biguanides can do this a little bit. You can also modify pathways within the kidneys, right, to prevent reabsorption of glucose. And so more glucose is being eliminated in the urine, right? There are even drugs that act on the central nervous system, right, to control appetite, for example, right? There are yet other categories of agents that work in the ways of some of these, but they essentially modify or they mirror the role of certain hormone-like substances. For example, glucagon-like peptide 1. There are agents that act like glucagon-like peptide 1. And these are interesting agents because they're not pills that you're taking every day, but rather they're injections that you generally take like once a week. And they can help lower blood sugar, and they can help decrease weight, help with weight control in some cases. And so these include medications like Ozempic, for example. It's a common one. Semaglutide, I believe, is the generic name. Trulicity is another example of a GLP-1 agonist, right? So you have all these different agents. So what are some big picture things that you need to know? Well, the major side effects, and of course, hypoglycemia is going to be one of the big side effects that we want to worry about, right? And so if anybody has signs and symptoms of hypoglycemia and they're on an antihyperglycemic, you need to, of course, check their blood sugar and treat them accordingly. But certain categories of agents have certain side effects associated with them. And I'm going to talk about two in general because they're super common. So I'm going to talk about the biguanides or metformin specifically, and I'm going to talk about the sulfonylureas as well. So let's talk about these sulfonylureas first. And so the sulfonylureas are really common. They're effective, but they do have some side effects associated with them. And let me just give you some examples of sulfonylureas. Amaryl is one. Amaryl, also known as, what is Amaryl known as? glimepiride. All right, glimepiride or Amaryl. Glyburide is another example of a sulfonylurea, also known as diabeta, or sometimes referred to as micronase. Glipizide is another example of a sulfonylurea, also known as glucotrol. All right, so those are just some examples, sulfonylureas. The major things that I want you to focus on with these are, these may be very problematic in patients that have chronic kidney disease. These can impact the kidneys. These can also cause weight gain, right? They can cause weight gain, they can increase hunger. Obviously, they can decrease blood sugar. And when used typically by themselves, we do see an increased incidence of cardiovascular and renal problems. So these may not be great drugs to give people that have substantial cardiovascular or renal disease, right? So those are the sulfonylureas. The other major one that I want to talk about is the biguanide metformin or glucophage, because it's super common and lots of people are taking it. So metformin or glucophage, should be a capital G there, sorry, and a lowercase m, whatever. And the major side effect that, or the major complication associated with metformin is metabolic acidosis, specifically a lactic acidosis can occur. And this can also occur if these patients receive IV contrast. All right. And generally speaking, if someone is on, someone has to be off of their metformin for like 24 to 48 hours prior to receiving IV contrast. So if you're in the emergency room, for example, and you're taking care of somebody, maybe they've come in with abdominal pain, they're getting an abdominal pain workup, and they need to have a CT scan with IV contrast. If they are on metformin and they've taken their metformin, right, that's a potential concern, right? Getting that contrast, and if no one has considered that, right, that can potentially be very harmful for that patient. Generally speaking, X-ray is very good about this. If X-ray comes down and they're going to take someone to some sort of radiological exam that requires contrast, that's one of the questions they ask that patient. But again, that's important for you to know. And this can occur without the presence of IV contrast as well. These people are just going to be more likely to develop lactic acidosis. And remember, that's actually on the differentials for an elevated anion gap metabolic acidosis. You remember the mud piles mnemonic? And remember the M stood for methanol and metformin, right, as differentials. And the pathophysiology of this, I've just include a little diagram. So how to occur? So accumulation of metformin in overdose situation, or maybe you have acute or chronic kidney or liver issue where you cannot eliminate or metabolize it appropriately, right? That can cause a kidney injury and acute renal failure, right? And you get an inhibition of mitochondrial complex 1, right? So you have an inhibition of activity in the electron transport. And so that causes a reduction in ATP production, right? And that reduction in ATP production activates certain pathways, AMPK pathways, to try to compensate for this, essentially a dysfunction of electron transport. And so what happens is this stimulates fats to break down, right? Beta oxidation, you start breaking down fat, so you can use that as a source of energy. And you also have a stimulation of glycolysis, right? Well, the electron transport system can't work, but I can use glycolysis to make ATP. It doesn't make a whole lot, but it's anaerobic and doesn't require electron transport. And so what you get is you get a substantial production of pyruvate, right? Pyruvate normally gets fed into the Krebs cycle, but that can't happen because Krebs cycle feeds into the electron transport. And so you get kind of a backup there. And so you're cranking out lots of pyruvate, and that gets converted into lactic acid. On the other hand, you have lots of ketone bodies that are getting pumped out as a byproduct of beta oxidation, right? And all that goes into the blood, right? And you have potential ketone bodies and lactic acidosis occurring, and that substantially increases the risk of acidosis. And then you put some IV contrast, and IV contrast is highly dependent on renal function for its elimination. So you inject IV contrast into somebody, and that will acutely hit the kidney. The kidney takes an acute hit. And most people, if your kidney functions normally, your GFR, your glomerular filtration ratios, 80, 90, 100, it's just not a problem. But if you're on metformin, something that is potentially inhibiting these, then adding that stress from the contrast on top of it may be enough to push somebody over the edge, and they may develop sudden onset acidosis. All right. Let's see here. It is already almost 9:30. So I think we'll go ahead and look at taking our first break. But before we do that, are there any questions? Anybody have any questions over anything we've covered so far? All right. Well, I will see you all at 9:45. 9:45. All right, welcome back, everyone. Let's go ahead and finish things up. We're going to finish up a little early today, and that's just because I have the final exam scheduled to open at 10 here in about 15 or so minutes, and that will give some of you the opportunity to take the final exam before lab if you so choose. You don't have to. It's open until midnight, but I understand with scheduling and all that, some of you may want to opt to take it prior to lab, just so you have the evening to focus on, say, work, if some of you are on shift tonight. So I want to give you that opportunity. All right. So any questions before we finish up? Make sure I'm up on chat. Okay, good. Well, let's just talk about the last major category of drugs, medications. These are super common. Lots of people are on them, so that's why I want to mention them. And these are medications that are primarily revolve around treating elevated cholesterol and blood lipids, hyperlipidemia or hypercholesteremia. There are varieties of agents that are used for this, or categories of agents, and I'll talk about some common categories and some major side effects associated with the use of these medications. So here's another diagram that I'm going to put up for you. So you can see that many of these medications really have to do with either hepatic or intestinal cycles or pathways. And so there are really two things that you can do when it comes to lipids and cholesterol. You can either prevent the absorption of cholesterol, because one of the ways we get cholesterol and fat is in the foods we eat, right? So you have categories of medications that work in the intestinal lumen to inhibit absorption. And then most of the other agents work primarily in the liver to reduce the production, because our body can create cholesterol. Because remember, cholesterol comes from lipids. Cholesterol is important, right? We need it. It helps support the cell wall, right? The phospholipid bilayer, the membrane, right? You have cholesterol in the middle of that helps support it. Many steroids and hormones, or steroid hormones, come from cholesterol. So progesterone, estrogen, testosterone, things like that. So it is important, but we know that too much of it can be a problem, because it can cause or be associated with plaques, atherosclerosis, and arterial sclerosis as well. And one of the major group of drugs that are used to control cholesterol are known as the statins. And the statins actually work by inhibiting an enzyme called HMG-CoA reductase. And essentially what coenzyme A reductase does is the acetyl-CoA that comes out, right? So you've got glucose becomes pyruvate in glycolysis, and then acetyl-CoA gets pumped into the Krebs cycle. And what can happen is some of that can get converted into cholesterol hepatically, right? And so what these statins do is these statins inhibit one of the major enzymes that catalyzes that reaction. It's actually the major rate limiting step for the creation of cholesterol. And so these agents, these statins, or these HMG-CoA reductase inhibitors, prevent the production of cholesterol in the body. And the reason I mention them is because they're very common, and these are some of the most common frontline cholesterol controlling medications, the statins. And I'll give you some examples of common statins. These all end with statin, so it's easy to remember. But let's see, atorvastatin is one example. This is also known as Lipitor, aka Lipitor. And simvastatin is another example of a common statin. Also known as Zocor. All right. So those are examples of statins. And there are many other agents other than statins out there that modify lipids and cholesterol. They're like your omega-3 fatty acid-based things like I could think of as some examples. Well, fish oil, right? Some people take fish oil, for example, can help with specifically with the LDLs, the low density lipoproteins, and the VLDLs, the very low density lipoproteins, which are the more problematic of the lipids. The HDLs, the high density lipoproteins, tend not to be as problematic. They're sometimes referred to as your quote unquote good fats, or your good lipids. And the omegas, the omega agents, are essentially slightly modified esterized fish oils that have been converted into drugs. Lavasa would be an example of those kinds of medications. So essentially there are lots of different categories, but the statins are a very common one. So I'm just going to focus on those for today. And the major side effects that I want you to remember when it comes to statins is these patients can develop severe muscle pain. And in some cases, they can actually have muscle breakdown and can develop rhabdo. It can develop rhabdomyolysis, right? So severe muscle pain and rhabdomyolysis are potentially life-threatening problems associated with statins. And when it comes to all of these cholesterol and lipid modifying drugs in general, another side effect of multiple categories of these drugs, because they primarily work in the liver, as you might imagine, is that there can be some hepatotoxicity. And so you can get an elevation in the liver function tests, the LFTs. So your liver enzymes can elevate when you're placed on these. And sometimes people that have lipid regulation disorders already have some underlying hepatic dysfunction, right? And a common one, we talked about this in pathophysiology, is something referred to as non-alcoholic fatty liver disease, or non-alcoholic fatty steatosis of the liver, right? And this is very common in people that have severe cholesterol and lipid dysregulation disorders. And so sometimes these drugs can exacerbate the underlying hepatic dysfunction. And what are the major liver function tests? Can you all identify some major LFTs that we would look at?
Albumin levels?
So albumin is very indirect. Yes, you can actually get a low albumin in the setting of liver failure, but there are many other things that can cause a low albumin. So it's not very specific. So I'm talking about things that are very specific to the liver function. These are enzymes that are actually released by damaged and dying hepatocytes or liver cells.
BUN?
No, that's a kidney, right? The blood urea nitrogen and the creatinine are primarily your renal function tests.
ASTs?
Yeah, the AST and the ALT are your primary liver enzymes. And typically along with that, your bilirubin will increase or can increase. But there are other things that can cause your bilirubin. If you have a lot of red blood cell destruction, like you have some severe hemolytic disease that has occurred, that can cause your bilirubin to increase as well. So bilirubin might not necessarily be a hepatic problem, but oftentimes it is when your bilirubin increases. But the AST and the ALT are enzymes that are specific to the dying, damaged, necrotic hepatocytes. So these are tests that we would look at to determine the degree of hepatotoxicity that may be occurring. All right, I think that's all I want to cover as far as the lipid and cholesterol medications in general. So let's go ahead and stop recording. So before I let you all go, one more time, anybody have any questions over what we're doing today, or any questions about the final exam? All right, the final exam will be opening in about 4 minutes in EMS testing. So you should see it open. You have a few hours to do it. I should say there has been a new paradigm that we'll be employing with this final exam, and I do want to let you all know about that real quick. This is something Ann talked to me about that they were going to institute. And so Platinum Planner, or EMS testing specifically, is going to be using some software that is going to monitor you taking the test. So it's not going to be video monitoring, not at this point at least, but it will monitor the way that you use your computer or device. And if it detects that you're trying to maybe take a screen capture or screenshot or record a video or open up another web page on the same device, it will notify us of this suspicious activity, and it may even shut you out of the exam. So when you go to take the final exam, make sure that it is on whatever computer you're using. Dedicate that computer just for the exam. Just open the one web page. Don't try to screen record it or take pictures or screenshot it, or open another tab at the same time, because that may be detected as suspicious activity. So this is, I guess, kind of like a anti-cheating and anti-copying software that they're going to be using on the exam. So I do want to let you all know that will be used starting with this exam. All right. Any questions? Any questions about the review? I know I posted the study guide. Just want to make sure that I answer everything before you all go and take the test. Okay. Looks like I'm caught up in chat. All right. Well, I don't have anything else for you all. I'm going to go ahead and conclude lecture here, and I will see you this afternoon for the psychomotor testing. Take care and drive safe if you're commuting.
Thanks, Chris. Thanks.
Thank you all. Yeah, thank you. Take care, everyone.